It's my pleasure now to welcome Joan Lynch to the podium. So Joan has over 20 years' experience of adult ICU nursing and is currently a lecturer at Western Sydney University. She has a postgraduate certificate in intensive care, a Master of Policy Studies, and is currently a PhD candidate. Welcome, Joan.
Thank you. I wonder where you got all that information from. I was wondering what you were going to say. So that's pretty true. So today I'm going to report to you the findings of a review that we carried out to answer a very basic question on the effectiveness of chlorhexidine bathing to reduce hospital-acquired infections among adult intensive care patients. So as we know, healthcare-associated infections amongst adult intensive care patients has shown to increase the length of stay, the cost of care, and the risk of mortality among ICU patients. Daily bathing with chlorhexidine gluconate has been suggested as an effective intervention to reduce the infection during an intensive care unit stay. However, the effectiveness of chlorhexidine bathing has been reported to be very variable within studies, making the effectiveness of chlorhexidine bathing in ICU patients uncertain and possibly reliant on the underlying risk of infection within units and within given ICU populations. Importantly, the current opinion of the merit of chlorhexidine bathing to reduce hospital-acquired infections among adults admitted to intensive care is divergent and suggests a current state of clinical equipoise. So the objectives of this review, we used some fancy methodology called trial sequential meta-analysis, which I'll explain a little bit more further on. Was undertaken to summarise the current status for the effectiveness of chlorhexidine bathing to reduce various infections amongst intensive care patients and also to address questions such as further research needed, like when do we reach that point where we have a definite answer, and whether the current research is adequate enough to answer the question, is chlorhexidine bathing effective? We recently carried out a normal meta-analysis, can I say, and it showed that the heterogeneity among studies was quite significant. And even though some effectiveness for the intervention exists, the results amongst the study was quite different. Some studies reported a very effectiveness for the chlorhexidine, whereas other studies that was only marginal. So we still weren't sure, after reviewing some quite good studies, whether chlorhexidine bathing was actually effective. So the whole point of doing the TSA, or the trial sequential meta-analysis, was to look at the variation among the results, aggregate samples from accumulating published trials, which was lower than we expected originally, and therefore we may underestimate the effectiveness of chlorhexidine bathing. So in an attempt to overcome these pitfalls, a trial sequential meta-analysis approach has been developed that attempts to address both type 1 and type 2 error, with repeated significant testings to accumulate trial data. So the meta-analysis was planned and undertaken as per the usual PRISMA guidelines. A systematic literature search was undertaken of the medical literature, and hand searching was undertaken until no further trials were identified. Due to our previous systematic review showing extreme level of heterogeneity among the before and after studies, we decided not to include those and only to include the randomised trials. Our outcome measures focused on bloodstream infections, central line associated bloodstream infections, multi-resistant drug organisms, and VAP and catheter-associated urinary tract infections. And this is the PRISMA diagram just showing our search results. So the electronic search resulted in 164 potential papers. We excluded papers that, it's down here, I've just realised. So trials that looked at chlorhexidine via the oral route or other methods, just central line dressings we excluded, just to include chlorhexidine bathing as our intervention. So we ended up with only 5 trials that were included in the final analysis, and all of these were either randomised or randomised crossover trials. These are the results. So we had 4 studies were included that looked at bloodstream-associated infections, and chlorhexidine bathing was shown to reduce approximately 30% of bloodstream infections just from bathing. CLABSIs were reduced by about 40%, and 2 randomised trials suggest that multidrugresistant organisms were reduced by approximately 20%. So all of these studies showed statistical significance, and I'll show you on the next page why TSA analysis is probably a better way of looking at whether we need to do more research or not in terms of looking at the existing research. The papers that were included that looked at VAP and catheter-associated urinary tract infections didn't show any effectiveness of chlorhexidine bathing in reducing infections in these sites. But it was definitely effective in bloodstream infections, CLABSIs and multi-resistant drug infections. So this is where the TSA analysis comes in. As we can see, our statistical significance, and this is for bloodstream infections. So as you can see, our statistical significance is set as Z statistic of 0.96, which is equivalent to a p-value of 0.05. So we are statistically significant, but this superiority line, we're still inside that line. So even though the studies we have show us that chlorhexidine bathing is effective, we can't conclude that we haven't done enough research. To reach the point of futility or superiority, we need to cross this line, the O'Brien-Fleming boundary, or we need to reach down here into the funnel of futility. And if we look at TSA analysis, it says that we need a required information size of at least 62,000 participants to be able to conclusively say whether chlorhexidine bathing is effective in reducing bloodstream infections. So we don't know whether this result is type 1 or type 2 error that's leading to a statistically significant result. Is that making any kind of sense? The next thing we looked at was CLABSI, and again we had a statistically significant result that suggested that central line bloodstream infections were reduced by approximately 40%, but again if we look at the TSA analysis, even though we're statistically significant, we still haven't crossed that boundary for the O'Brien-Fleming of superiority, and we've definitely not got the numbers necessary to be able to say we've got the required information size to make that a conclusive result. So we're heading there, but we're not there yet. Our next one is multidrug-resistant organisms. So again, we're reduced by 18% by using chlorhexidine bathing, but again, although we're statistically significant, we're still not crossing that O'Brien-Fleming boundary for superiority or having enough of a required information size to make those results conclusive or sufficient to be able to incorporate chlorhexidine bathing as a standard of practice within our intensive care units. So the same again for VAP. Although we didn't find any effectiveness in reducing ventilator-associated pneumonia, some observational studies may err towards increasing ventilator-associated pneumonias with the use of chlorhexidine bathing, but there definitely isn't enough research currently for us to be able to conclude whether chlorhexidine bathing is either effective or superior or inferior in causing ventilator-associated pneumonias. The next one was catheter-associated urinary tract infections. Again, we didn't find any effect of chlorhexidine bathing. There may be some with a null or may be harmful, but we certainly don't have enough evidence to be able to draw those conclusions as of yet. So I think the take-home message that although there is 5 well-designed, well-conducted studies examining chlorhexidine bathing and reducing certain infections within the intensive care unit, TSA analysis suggests that we need more trials to help address this current state of clinical equipoise. Ideally, these studies should be conducted among a diverse group of ICU patients and to the highest standards to ensure generalisability of results. And TSA analysis has provided us with a way of quantifying whether we're there yet and whether we need to keep doing studies or whether the research is sufficient enough to be able to draw a conclusion. And I think they've done recent TSA analysis in the cooling during cardiac arrest, and they've been able to answer that question conclusively. So what's next? We need collaborators, of course. Maybe we can all sign as we walk out the door, sign up for each other's studies. But definitely we need some large multi-centre trials across Australia and New Zealand just to answer some very simple questions but answer them well until the point of certainty. Also, there was another question about whether we use pre-packaged wipes to make care standardised and which outcomes should we focus on, because we know if we look at different sites of colonisation or infection, the outcomes can be very different. Thank you.
Joan.
Have we got any questions from the floor for Joan?
Sorry.
Oh. No, it's all being recorded.
Thanks, Joan. That was great. Can I just ask, in any of the studies that you looked at, was there any talk about chlorhexidine resistance at all?
Particularly with gram-negative bacteria. There was that question of whether we do, but the studies we've looked at the outcome hasn't been measured for long enough, and that was one of the major problems within the studies, was time to follow up. Was it long enough to really measure the outcomes of interest? Yes, but that has been mentioned, of chlorhexidine resistance.
Great, thanks, Joan.